Good morning. Sorry for the late start. Apologies for the delay. So good morning, distinguished heads of ministries, departments, and agencies, Health Policy Commission members, captains of industry, heads of associations, development partners, the research community, distinguished ladies and gentlemen, joining us online and also in this auditorium. Thank you so much for making out time to be here at the Health Policy Commission's first General Assembly of the year. My name is Shay Vincent. I'm an anchor of the Health Policy Commission and also an economist here at the NESG. Okay, so I'll just be going through the agenda as briefly as I can. So we'll have Mr. Patrick Aja. He's the private sector co-chair of the Health Policy Commission's steering committee. So he'll be giving the opening remarks. So Mr. Aja is the MD CEO of May and Baker Nigeria. I'm sure you're all familiar with him. We also have a public sector co-chair in the person of Mr. Mahmouda Maman. He's the permanent secretary of the Ministry of Health. Unfortunately, he couldn't join us here. Mr. Shiju Olanubi, he's the acting head of think tank operations at the NESG. He'll be giving a brief presentation on the NESG, our policy commission structure, and how things work with regards to the policy commissions. Dr. Maria Saleh and Dr. Ola Brown will provide an overview of the activities of the Health Policy Commission 2022-2023. So Dr. Maria is the Health Policy Commission's thematic lead for public health. So we have two thematic groups, public health and health as a business. So Dr. Maria heads the public health side. So she's also the chief of party FHM Engage project at Chemonics. Dr. Ola is the thematic lead for health as a business, and she's the founder of Flying Doctors Healthcare Investment Company. So they'll both be joining us online. So after that, we'll have context setting from Dr. Hamza Abubakar. He's the executive secretary, Kaduna State Primary Healthcare Board. So he'll be doing the context setting from the perspective of the government. Then we have Dr. Laz Ude Eze. He'll be setting the context from the perspective of a healthcare user. Dr. Laz is the MD CEO of Talk Health Nigeria, a health policy advocate and also a development consultant. Okay, so just a bit more to go. Okay, so as you may know, the Health Policy Commission put out a call for submissions on health system strengthening earlier this year. The DRPC, the Development Research and Project Center, supported the review of our submissions. So we have Dr. Turnwaite Michael. He's a research consultant at the DRPC. So he'll be speaking to us about the selection process for the proposals that we're choosing. So after his brief presentation, we will have the authors of the top submissions. So 5 of them will be giving their presentations. After that, we'll have Dr. Laz giving an overview of the presentations. We'll have a Q&A session, and then we'll have Dr. Morris, who has introduced herself, our facilitator, who will give the closing remarks. So we'll try to speed things up and so we can finish by 2 p.m. Okay, so thank you all for honoring our invitation. So I'd now like to introduce Mr. Patrick Aja. So Mr. Aja is the private sector co-chair of the steering committee, as I said earlier, and he's also the MD CEO of May and Baker. So Mr. Aja is a passionate and visionary leader with over 2 decades of progressive experience and responsibility in various business environments, from pharmaceuticals to FMCG, telecoms, and manufacturing. He really doesn't need much introduction. I'm sure his profile speaks for itself. So I'd just like to invite Mr. Patrick Aja to give his opening remarks. Thank you.
Thank you so much. First of all, let me apologize for keeping us waiting. I'm really, really sorry about that. Sometimes you think you can predict Third Mainland Bridge and the traffic. It doesn't always work out that way. I also see we have a very rich program today. quite detailed. There's going to be a lot of presentations, so I'm going to try as much as possible to make this opening address very short. So first, let me recognize distinguished heads of ministries, departments, and agencies, both here and those who are joining us online, Health Policy Commission members, captains of industries, heads of associations, development partners, and of course the research community, and of course distinguished ladies and gentlemen. It's difficult to recognize everybody, but we do appreciate all of us that are here this morning. It really takes sacrifice, especially for those of us coming from the mainland, to be here this early. It obviously underscores how important our roles are, both as captains of industry, MDAs, and policymakers in driving the economy of the country. It's also a privilege for me to make these opening remarks. Like she said, I'm one of the smallest ones. I just managed to sort of hold on for the private sector, and I think it's important that that collaboration happens if our economy is going to move forward. I don't do so much of the work. I just make some of those comments, and I prefer to listen and learn a lot, because those of us who lead organizations know that this is a tough time in this economy. And I believe the interactions we're going to have today will go a long way in helping to ease some of the headache we're having, which is one of the reasons why I had to be a bit late. The Health Policy Commission is a recent creation of NESG in recognition of the importance of health in socioeconomic and human capital development. I believe all of us can speak to that, because if for nothing, COVID-19 taught us a whole lot of lessons. When we were all shut down and a whole lot happened, infrastructure and everything, many economics, many companies. I know companies that had to either lay off staff or fold up. But it also exposed the vulnerabilities in countries like ours, where sometimes we don't think about these things, we just wait for it to happen to us. And that's why we're gathered here today, that going forward, we should be able to help government to make sure that we don't wait for things to happen to us. We prepare for them before they happen. So the overarching mandate of the Health Policy Commission is to serve as a platform for public-private dialogue to drive reforms that guarantee not only health for all, but health by all. And I think that's a concept that I believe the experts are going to dwell on. All of us should have known that if you wait for health for all without doing something about it, it may never come. But all of us as organizations and individuals should play a part and actually take responsibility for our health, knowing, like they say, that health is wealth. And this mandate is subsumed to attain the universal health coverage, which is one of the SDGs by 2030. Is audacious, but when we get committed, both as private sector and public sector, they said if you aim at the sun, at least you can hit the moon. I know many people think it's impossible to achieve universal health coverage, but we can't wait and think it's not possible. We need to make concerted efforts to see that happens. So the HPC General Assembly provides an opportunity for HPC members, partners, and associates to learn about the activities of the Health Policy Commission and discuss important issues concerning the health sector and the HPC's agenda, which I think is what we're doing today. This is the first one for the year. So this allows us to be able to get feedback from, both private sector, public sector, all these other experts, like some of the ones that we're going to be hearing from today, and to help us advise policymakers on the way to go if the country is going to need to move forward. So as you know, we are in a very defining moment in our country. In less than 2 months or thereabout, a new government is going to take over. And when that happens, many people start rushing to Abuja and there will be suggestions and a whole lot of things. And I think NESG needs to play a significant role in, we already know that health has not been given the right kind of attention. And these are areas we should be prioritizing. And I think that's why this meeting is important, and the interactions that will happen after here, so that peradventure the next administration will listen to us in making policies. In the last 2 weeks, I've delivered keynote in some of these significant places, and I think we all have the same agreement. Sometimes we focus on building roads, we focus on doing all of that, and the people we are building it for, they are not healthy, and they die. And I believe that the experts are going to help us channel our thoughts towards making sure that we'll play our part in helping the new government to make the right kind of decisions. So it's generally known that a well-functioning health system working in harmony is built on having trained and motivated health workers, well-maintained infrastructure, and a reliable supply of medicines and technologies backed by adequate funding, robust health plans, and evidence-based policies. I can tell you, we are not where we should be. At least I feel it on a daily basis. Especially if you have to deal with things like vaccines and all of that. Sometimes we do not quite get the value that we need to get for the kind of money that we invest. And that's why these kinds of meetings are important, so that peradventure we might be able to help the government understand the way these things need to work. I don't intend to take so much time because, like I said, we'll have a very loaded program. But I believe that to ensure the long-term viability and efficiency of Nigeria's health system, the Nigerian health system needs to be strengthened. We know there are challenges. All of us know that. But we can't wait, like I've said. We need to address these challenges. So this General Assembly will provide a platform for discussing Nigeria's health sector. The HPC called for, like she said, we called for proposal from experts, and some of those proposals were selected, and we're going to be listening to some of them, and it will help us make a decision on the ones that should guide the proposals we're going to be making and the direction that NESG and especially the HPC will be going for the rest of the year. So the HPC leadership, Dr. Maurice Atoke, Dr. Ola Brown, and Dr. Maria Saleh will speak more on the work and success of the Health Policy Commission. Like I said, I'm not as smart as they are, so I just make the simple introductions, and they are the smart people who are going to enlighten us more on this. I prefer to take notes because right now, people like us are having a lot of headache on how to make supply of medicines a lot easier and where to get Forex to make the next importation for raw materials. So please, if you know where I can get some Forex, I'll be ready to take notes. So once again, I welcome you to the first HPC General Assembly of the year, and thank you for your continuous commitment to the reform of the Nigerian health sector. I look forward to your contributions and insights on these critical health system issues. And like I said, I'll be taking notes. Thank you so very much. It's really a pleasure to be here today.
Thank you so much, Mr. Aja. Thank you for your opening remarks. Okay, so now we will move on to a presentation from Mr. Sijo Olanubi, who is the acting head of think tank operations at the NESG. So he'll be giving a brief presentation on the policy commission structure. So Mr. Siju, please join me in welcoming Mr. Siju.
All right, good morning, everybody. I would like to stand on existing protocol. All right, my work is very simple here. I'll try to manage time because we are kind of trying to catch up with time. What I want to do basically is just introduce us to the NESG. I know many of us have read about the NESG onto our website, and but I'll just try to within the next 15 minutes give a crash course, if I can call it, about the NESG, what we do. So I've titled my slide Mandate, Strategy and the Future of Advocacy at the NESG. I hope to manage time very well. Okay, so normally like to start with this interesting quote by Kendon, 1984. It says policy change and impact comes about when three streams, problems, politics, and policies connect. Each stream has its own forces acting upon it and ultimately influencing it. The streams do not just converge by chance, but rather from consistent and sustained action by advocates. Some people, as you know, if you must have heard it, say, oh, NSG, they will meet again in Abuja, October for their summit, and then it's a talk show. They've been saying this since 1993, and nothing has changed in the Nigerian economy. So this quote says that for these streams to converge, problems, politics, and policies, we know the problems. Many people know the problems. But of course, we know that you can't jump from the problems to policies. You need to engage, the political actors. You need to engage the government. How do we now converge from understanding the problems, talking about the problems, to ensuring that we have policies that would actually engender the growth of our economy? Kendi says we should not stop, by just advocating once, but we should be consistent and ensure that the advocacy is sustained. So generally, we believe strongly that as we continue to sustain our advocacy efforts, that, the change that the country is actually looking out for will eventually have it. And by the way, we've recorded some success stories along the way, which I'll just try to point us to. But it's just to say, for those who are passionate about the Nigerian economy, passionate about reforms of the Nigerian economy, we must not relent. We must continue to sustain our advocacy. The streams will one day converge. Okay, so our vision is to become Africa's leading private sector think tank committed to the development of a modern, globally competitive and inclusive Nigerian economy. And of course, our mission is to promote and champion the reform of the Nigerian economy into an open, inclusive, sustainable, and globally competitive economy. Now, these words are very important. The word open, because when the NESG came on board, it was a military regime. That context, and the Nigerian economy was not open. We're running a closed economy. We can't talk about inclusive. We can't talk about sustainable. We can't talk about an economy that was globally competitive. So the NSD came at a time that Nigeria needed to, shift in terms of the way the trajectory of the economy was going. Our values, guiding principles. I'll just try to move fast on some of the slides. And so, how have we tried to? So we believe that one of the ways, 4 ways, or we call them our 4 strategic pillars or roles, by which we believe we can actually drive sustainable change in the Nigerian economy is, serving as dialogue partner, which is what we're trying to do today, bringing private sector actors, public sector actors together, because if you notice, both groups are actually don't necessarily, talk together. The private sector actors are thinking about so many things, how to drive their, how to have a good business environment, how to ensure profitability. While the government is thinking about policy and the likes. So our role as a partner, we try to ensure that both actors sit together on the table and have sustainable dialogue. Then connector role, we try to connect the private sector and the public sector together, not necessarily having to dialogue again, but at times what is required is just some connection. For top executives in the private sector to meet with top executives in the public sector. We try to do that. Then watchdog role, which we do basically through our research. One of the things we believe at NSG is that you can't drive policy change by just having wishful thinking or just having some thoughts flying around. We need to anchor what we are doing, our interventions, on evidence. And so that's the role we play as the watchdog. And then intervene. I've discovered that people have said, hey, NSG, you guys just talk. What about implementation? What about this? What about co-creating policies together? What about giving government, providing technical assistance to government, just like development partners do, and also serve in that role. Let me try to run. Okay, just reiterating that. Okay, so how did we actually evolve? The story of the NSG, is the story of Nigeria from the year 1993, where we held our first dialogue. Of course, so before the NSG came on board, 1985, 1996, we know what was the Nigerian economy. The economy was closed. It it was an economy that was not growing as it ought to, based on the potentials, right, that it had. And then 1996, 1999, that was the infancy stage, the stage of a closed economy. That was when NESG was intervening that you have to open this economy, based on the private market principles that believe that allow the markets, allow the private sector to actually run the economy while government does the role of the regulator. And then the early opening phase, when, of course, we succeeded in some of our interventions, our recommendations succeeded in opening the economy. 1999 to 2007. And then the Vision 2020 era, NESG was instrumental in crafting the Vision 2020. And of course, where we are in 2019 to 2050. Why 2050? Because the NESG, at one of our summits, we told the government we need to return back to that, to the era of National Development Plan. Because that was actually, we actually paused when we entered, we had the ELGP and the likes, but we paused the National Development. So we told the government, let us return back, to that era of planning. And that was why we have the National Development Plan, the Medium-Term Plan, and then Agenda 2050, that was just recently approved. Okay, some of our key impacts from 1999 to 2006, the banking sector reforms, telecommunication reforms, the GSM reform revolution that saw liberalization of the sector and brought in private sector players, MTN and the likes, were instrumental to that. Maritime and seaport reforms, power sector reforms. Of course, people will say power sector reforms the reform hasn't yet crystallized fully, but the initial conversations of from NEPA, PSN and the likes started. We were instrumental to that. This just shows our economic summit and the various teams, how those teams. So what we try to do at our summit is to shape the agenda, the national agenda for the country. What are the key priorities that the government should be looking at going forward in a particular year and a particular era? We try to shape it at our various summits, trying to move fast. Okay, the impacts in Vision 2020 era, some of them are there. And then, so recently, one of things I mentioned earlier on, we worked with the government in developing the medium-term development plan and then the Agenda 2050, provided technical support. We were on various committees, drafting committees and the likes that brought about the National Development Plan, both the medium-term plan and then the Agenda 2050. And then, if anybody likes sports here, we have a national sports industry policy where, the whole process of, co-creating from the scratch started at one of our summits. The idea started, and then one of our policy commissions, a thematic group, the sports industry thematic group, started that process, midwife the process, working with the government, and then we have a national sports industry policy that, has at its center private sector participation and funding of the sports industry. And of course, the Triple Helix Roundtable, I believe that government, private sector, academia should work together, and that's how we can drive sustainable innovation and economic growth. So we started the conversation many years ago, but recently the third one has given the go-ahead for the operationalization of the secretariat. Okay, so let me jump into the framework that guides the way the public, our policy commissions work. We call it PPD, which is public-private dialogue. It's actually a framework, and there is a global best practice that we've adopted in ensuring that, so it's not just about bringing people in the room. There's actually, there's some principles that undergird that process. Okay, before we go into that, just to introduce us to our various platforms, we have policy commissions. Of course, the Health Policy Commission of the policy commissions. What are policy commissions? Basically, policy commissions are working groups comprised of experts in both private and public sector that meet to see how they can actually drive reforms in their various sectors. We also have roundtables. We have committees of practice, and across the policy commissions, roundtables, and committees of practice, we have working groups. that work to see that the various work plans of policy commissions actualized. Okay, these are the various policy commissions at the NESG. We have 11 policy commissions, basically 12. We also have the education, but in terms of personalization, we've operationalized 11, and the Health Policy Commission is part of the policy commissions that we have. This just retraces the previous slides. Okay, so what's our strategic positioning? We are national in terms of our focus on the Nigerian economy. Some think tanks focus on the local, maybe states, or maybe local, but we focus on general economy-wide. We are permanent. Our leadership, of course, private sector driven, and many actors, of course. We believe that we need to mobilize various stakeholders, engage. When we were working on the National Sports Industry Policy Commission, they engage different, stakeholder groups and actors. You can't just, we just have an idea and then, this is the best idea in the world, we run with it. No, we try to engage actors, through experts, forums, engage them through dialogues to ensure that we have, what we are presenting is has, the buy-in of the various actors. Okay. So, when the private sector sits to discuss what's in their head, where can I get some funds to run my business? And like Mr. Patrick has mentioned, Forex. The private sector, this is what is in private sector's mind. So let's see what's on the public sector. What's on the public sector's mind? How can we help banks to give more loans to SMEs? What trade deals will benefit our country? How can we ensure that our workforce is more skilled? So you could see the different divergent thoughts in the heads of the minds rather of the private and public sector. So what can we do? We need to actually bring both actors together. Because one understands the sector, understand their pinpoints, and the other understands the policy needs. Then what we try to do is to synergy between the private and public sector, so that they come together and then they can speak, face to face, and they can discuss and dialogue on how they can move the economy. So that's what we try to do. We try to move very fast. Okay. The governance structure of our PPD platforms we have NESG board, we have board committee on policy commission, the CEO, then the policy commissions. This shows from the board level. Now let's delve into the policy commission level. The apex governing structure is the steering committee. So the steering committee, high profile personalities in the various sector specific to the particular policy commission, demonstrated years of experience and understanding of the sector from both the private sector and the public sector. So we have two co-chairs, the private sector co-chair and the public sector co-chair. Public sector co-chair, of course, for Health Policy Commission is Mr. Patrick Aja. And then we have the public sector co-chair, the chair, the policy commission, the chair, the steering committee meetings. And then we have a working committee next that is made up of the facilitator, thematic leads, and a champion. Who's the champion? The champion is an individual or an entity that is passionate about the sector, that is willing to invest resources in terms of financial resources and then time to ensure that specific interventions, within the sector are driven to actualization. Then we have the facilitator, of course, who heads thematic leads, and then we have, of course, within thematic layers, working committees. Of course, then we have a support system for the policy commission. We have an anchor, and then we have bridge fellows that also provide support. I'm trying to run. How policy commissions work? Let me run. Okay, let me just try to touch on the PPD guiding principles. I mentioned that we have, we don't just bring actors together, private sector and public sector, and just, begin to talk. We have a principle that guides such engagement. So we believe the first guiding principle is there has to be a mandate. People shouldn't just meet without a clear mandate. It has to be, it has to be articulated well, written down, and then the policy commission has to be aligned to the various institutions within the sector. It shouldn't be that, the institutions that are actually very relevant in driving productive sector are not within the policy commission. So we try to ensure that there is institutional alignment across the various value chains. For instance, health has different value chains. Ensure that institutional alignment. Then structure and participation. We try to ensure balance between private and public sector. Then champions on leadership. I mentioned earlier on that policy commission has leadership, steering committee, facilitators, thematic leads. Facilitation and management, yes. Steering committees have a facilitator that provides oversight over the policy commission and manages the affairs. Then we don't just meet and talk. We have outputs, both hard and soft outputs. Hard outputs in terms of what tangible can bring out from a meeting, maybe a report, and then maybe we sit together and we drive a tangible policy change. Then outreach and communication, we try to take whatever we discuss to the general public. Then there is a way we monitor and evaluate the effectiveness of our policy commission as a framework that we use. And then we try to ensure that the policy commissions are also aligned in terms of we have subnational presence, sector-specific relevance to FDI, post-conflict, disaster, crisis management. Ensure that policy commissions don't just act aloof of if there is a crisis in the sector or disaster, don't just act aloof as if we're trying to just focus on policy, and then there is crisis that they can actually also intervene. And then we try to also align with development partners. Okay. I will just move fast and then end with the risk to, public-private dialogue risk. Just try to end with this. Next, maximum 5 minutes. Okay, so we have public-private dialogue, but just like we have the benefits of public-private dialogue, we also have risk that we try to manage. The first is vested interest. What we do at the NESG, we say we do everything in the national interest. We don't care who gets the glory. And that's what has actually kept the NESG here. We try to do everything in the national interest. We're not trying to drive the interest of any organization. So that's why the PPD platform helps, to dilute there's any vested interest. When people meet together and then a proposition is passed, people can, objectively, debate it, and then we can also rely on evidence, to drive such proposals so that we try to guide against vested interest. So we try to also ensure that our PPD platforms are fully representative, that they do not lead to a talk shop. There is an clear agenda for meetings. There is a mandate. There are clear, deliverables, outcomes, so that it's not just people coming together to talk. Risk of hijack or one-man show. That's why we tried. When there is adequate representation, there won't be a risk of one-man show. Risk of being politicized. Well, so NSG, we say we are political. We don't belong to any political party. What we just focus on is driving reforms for the growth of the Nigerian economy. So we're not political. Risk of duplication of efforts. We try to ensure that policy commissions work together, so that because there are some issues that are cross-cutting across policy commissions. Thank you.
Thank you so much, Mr. CG, for that very insightful presentation, and I think you did that in a very, very good time. Okay, so we're going to move on to presentations by Dr. Maria and Dr. Ola. So I introduced them earlier. So Dr. Maria is the thematic lead for the public health thematic group. So we'll start off with her presentation on the activities of the Health Policy Commission. So do we have Dr. Maria online? Welcome, Dr. Maria. Can you hear us? Dr. Maria, we can't hear you. Are you muted? Oh, you're muted. Yes, we can see that. You're muted, Dr. Maria. Okay, so let's just try to sort out that issue. Can you hear us? Can you hear us, Dr. Maria?
I hear you. Can you hear me?
Oh, fantastic. We can hear you now.
All right. I think it was my headset. All right. Thank you. Can I have the slides up, please? Good morning. well, now afternoon. Good afternoon, distinguished guests of the Health Policy Commission. I will take you very, very quickly through some of the activities that some of the activities that the Public Health Thematic Group has undertaken in the last year, and some of the ones we'll be undertaking in the next year. We have developed a white paper on enhancing local production of medicines and vaccines. We also have a health financing white paper that is currently being updated. It had been developed last year, and we had a brainstorming session with health financing experts last week, and we got a lot of insights which we will be using to update that document. We also hosted an interactive panel session on universal health coverage and the basic healthcare provisional funds during the Nigeria Economic Summit Group Summit in 2022. We have engaged other policy commissions within the NESG, including the Trade and Fiscal Policy Commission, on how we can apply the sugar sweetened beverage tax to financing some of the gaps in the health sector. The thematic group also reviewed the national vaccine policy, and we participated in several events leading up to the finalization of that document. At the end of 2022, we identified additional areas of focus, one being financing primary health care. And that is really recognizing that the BHCPF might not be sufficient to help us reach universal health coverage. And the second being, sorry, can't see the slides on this presentation. Okay, I'll just move on. Yeah, thank you. It's gone off now. So we also, this is just more detail on the white paper for enhancing local production of medicines and vaccines. So this happened really in response to COVID-19, when we had to wait for the world to donate vaccines to Nigeria. And in keeping with that, we had a roundtable in 2021, and then subsequently a white paper was developed. The document examines the feasibility of domestic manufacturing of medicines and vaccines. It summarizes the constraints and enablers, and finally it made recommendations. Fairly recently, we also presented this document to other policy commissions, and we received additional feedback on how we can move forward on this activity. So more of moving from speeches and speaking and more to action. And I already spoke about the review of the national vaccine policy. So I'll just leave it that to save time. So I think that's the last slide. Thank you very much. Over to you, Dr. Shi.
Okay, thank you so much, Dr. Maria. So unfortunately, Dr. La is not able to join us, but I'll just mention very briefly. So her thematic group, the Health as a Business thematic group, is developing guidance on attracting funding and potential pitfalls for health sector players seeking investment. So that's one of the key pieces of work that thematic group is doing, and hopefully, at some point in time, she'll be able to brief us formally about the activities of that thematic group. Okay, so we're now going to move on to context setting. So we have Dr. Hamza Abubakar, who is the Executive Secretary, Kaduna State Primary Healthcare Board, who is going to set the context on health system strengthening from the government's perspective. Do we have Dr. Hamza online?
Yes, we do.
Oh, fantastic.
Afternoon, everyone.
So,
can you hear me?
Yes, we can hear you.
Thank you for having me, and thank you always to the group, for involving us from the government side in all that you've been doing. My task is quite easy, yet difficult, because I can actually right now just say the health system at the moment is not working optimally, and I can close. And I assure that 99% of us in this meeting would agree with me. Even before giving any evidence that I've prepared, this small evidence, that I've prepared. Now, it's still the most difficult task. Why? Because we are not doing well. And you know how difficult it is to self-appraise, how difficult it is for people to accept that this thing I'm doing is actually not working, or maybe this method or this strategy I'm employing is, not yielding results. So, but I always like to open with kind of a good outlook. And what is this good outlook? Is the fact that Nigeria is a beautiful country, of more than 200 million people, of great wealth and great potential. We used to have a very strong health system. So there's no reason why we cannot, with this day and age, with knowledge, with globalization, with technology, there's no reason why we cannot go back to those days of, a very strong health system. We have, at the moment, a very good structure, in my opinion. I think what we are doing is, where we are failing, is we are not using to the optimal level this structure. The health system is, I think, one of the most widespread, has one of the most widespread tentacles across the country. Almost every settlement has some sort of presence, but we need to do better in making this structure work. We have in the country fantastic manpower and skilled people. The current structure here, I mentioned it in the introduction because in some of the challenges I'm going to mention, it will, feature. And we know we are operating at 3 levels in the country for the health systems: the primary, secondary, and tertiary levels. Next slide, please. So, I took, I think, about 3 or 4 indices, the most important, maybe groups of indices from the multiple indicator cluster survey of 17 and 21. Not even looking at the NDHS, the SMART survey, and so on, just to compare where we are going. So with child mortality, we can say we are improving. But believe you me, from 39 per 1,000 to 34 is not a remarkable improvement. That's not where we ought to be. So also for infant mortality, and especially for under 5 mortality, which is one of the major key indices that you use to assess any health system. Next slide, please. For maternal mortality, okay, this is immunization coverage. Do we have maternal mortality? Oh, wow, I missed it. So sorry. Let's go back to immunization. We're improving on immunization, but there are many issues with the sector. From 33 to 57 is good. But again, is this where we ought to be as a country after all the years of experience, after all the investments? I would say not at all. So also measles. So these are just indicating, giving a few snapshots of where we are with immunization. Next slide. Now, I think from this one slide, we can make some connections to why, forgive me, I regret not sharing our maternal mortality indices. I'll maybe share after this meeting. But this slide actually is one of the key indicators of why our maternal and child indicators are so poor, in my opinion. Up till now, we are only 50% in terms of skilled birth attendants taking our deliveries. In 5 years, we moved just 7%. And the sad thing about it is, you know, there are many layers to unpack, but this one is just an average. In the southern part of the country is way better than this if you put the averages together. But in the northern part of the country, believe you me, if we break this down to states, some of us will not be happy here with our level of attendance, skilled birth attendants taking our deliveries. So this is one of the major issues that we can unpack. Why are our pregnant mothers, despite almost 80% ANC visit, are, you know, refusing to come to the hospital and have their deliveries attended by someone who is skilled? Or even if it is at home, why not get someone who is skilled? These are some of the things I'm sure the Health Policy Commission is working on to find out. Next slide. Now, why do we have all these issues? Looking at it from a general systemic point of view, I think we have an unbalanced system. You recall, I told you we operate at primary, secondary, and tertiary. This is clear from our side that there is much more funding going to the apex, where they are supposed to just handle specialized services. The apex, by the apex, I mean the tertiary level. There's also a better needs-based supply chain and equipment inventory, still at the maybe general, but mostly at the tertiary level. Now, the base of the pyramid, which is the primary healthcare level, that's supposed to take care of at least 70% of the health burden in the country. We've done well in the past few years with, you know, interventions like Basic Healthcare Provision Fund and so on. We are really now bringing PHC to the front of our priorities. But still, I think PHC in our budgeting and other, you know, government prioritization and planning is still being neglected a bit. Of course, the whole system is characterized by poor infrastructure, inadequate manpower, and, you know, persistent stockout of, you know, supplies and commodities. And what is the outcome of this? Is the most vulnerable in our population are still, you know, bearing the brunt of this underperforming system, unfortunately. So I tried to break the, you know, presentation. Sorry, I'm taking too much time, to some of the building blocks of health system. If you look at service delivery, I think I've already mentioned some of the issues there, looking at it from the demand and supply sides. Definitely there's perception of low service quality by the people. Maybe it's one of the reasons why they are not going, for example, to have their deliveries attended by our skilled staff. There's also high cost of care, high cost of going to the facility, if you look at geographical constraints and so on. And then when they visit the facility, we still, especially at primary healthcare, tertiary and secondary, that one I don't even need to mention. Primary should have been the most affordable, accessible one, but it's still quite expensive. Even now, our cultural norms and practices are still a hindrance. Looking at the supply side, I've mentioned, you know, in one sentence, the poor lack of, the poor infrastructure, no equipment, unavailability of commodities and so on. Next slide, please. In health financing. So the Abuja declarations, you know, says our government has pledged to commit at least 15% of its budget to health. In 2022, we've had only 4.88%. This can take us nowhere, I'm sorry to say. Even the 15%, I don't know how much it will go, but at least let's try. Some states have been consistently making provision of at least 15%, but the cash backing is still a challenge. You would see, even though you have 15% of the budget, your budget performance cash-wise maybe is around 30, 40%. So basically that 15% transmits back to this 4.8, around 5% performance. And then, of course, our out-of-pocket expenditure. If you look at the three major mechanisms of health financing in our country, I've mentioned budget. The health insurance is coming on now, especially with the advent of all the state health insurance agencies and authorities. But out-of-pocket expenditure is still very, very, very high. We cannot have a sustainable system when people in such a country of such economic hardships, 75% of payment for health is out of pocket. It's not feasible. Next slide, please. Our human resources production line is inadequate. And by that, I mean the schools. You know, so many accreditation challenges, so many indexing issues, so much demand in terms of investment to have them accredited or to have their indexing numbers increased. And I understand where all these registration councils are coming from. We have to maintain some level of standard, but it's still a challenge because the money and the investments are not there in the school. We don't have adequate post-training and in-service skills development, as well as a lot of maldistribution of our human resource for health. You talk of people preferring to be at tertiary and secondary levels than primary. And then even in the primary, since about 70% of primary healthcare centers, excuse me, are in the rural areas. So our staff tend to want to stay more in the urban area. So this is really a difficult situation. And of course, the brain drain or JAPA that these days have been a bane for our health system. Next slide, please. It's quite clear with medical products. I'm very happy with the white paper. There's no two ways about it. We need to ensure local production of drugs and commodities, as well as vaccines. Now, when we say drug production, I would also go as far as talking about research and development, not just buying. Let's start with buying patents and producing here, but I think we have to do better in terms of researching and developing our own drugs and vaccines. Our logistics systems are relatively good at central, but very, very, very weak when you come down to the states and the local governments. And then, of course, the public-private sector, the public-private partnership that we have is minimal in the country. We need to do better. And we need to regulate the whole system, the whole ecosystem better. Those that are producing should be regulated, the market should be regulated, and we must ensure our borders are closed, to all these non-registered, unverifiable drugs that keep coming. So this is to set the context, but I cannot finish without, mentioning some opportunities. Government is still committed to health. There is no discussion. This I can assure. There is no discussion of leadership that happens, of setting an agenda, be it a political party or a government that has been elected, that there is no discussion and prioritization of health. Maybe it's the way we are going about it that, is inadequate. I mentioned how widespread our structure is in the country. Let's use that as an opportunity. Let's immerse ourselves, into this structure and make it work. There's a country of more than 200 million. Anywhere is a huge market. So I would like to encourage, our business partners to invest more. And of course, I would always mention the basic healthcare provision fund. It's a huge opportunity, but we need to do better with it. Next slide, please. Thank you very much. Sorry, I think more than the time I was allocated. Thank you.
Thank you so much, Dr. Hamza. That was such an insightful presentation, highlighting some of the issues we're facing, recommendations and opportunities, which I'm sure our partners have taken note of. Okay, so now we're going to move over to Dr. Laz Ude-Eze. So he's the MD CEO of Talk Health Niger. He's also a health policy advocate and development consultant. So he will be setting the context from a user perspective. So do we have Dr. Laz online? I believe he should have joined us. Dr. Laz? Dr. Laz, are you with us? Welcome, Dr. Laz. Can you hear us? Oh, yes. You're muted.
Okay.
Great,
yes,
fantastic.
Can you hear me now?
Yes, welcome. Over to you, sir.
Okay, thank you very much. Thank you very much. Good afternoon, everyone. I have like 10 minutes to make this presentation. I'm very excited that Dr. Hamza, has kind of provided a lot of data that makes my job much easier. I'll be speaking from the user or civil society organization perspective. User, which is the users of our healthcare systems and facilities, which essentially is the patients. Any of us could be patient. I wouldn't be dwelling much on my person, but just to provide a kind of background. I'm in the job of health communications. I do this through a lot of media platforms. I present a program on AIT, Talking Health with Dr. Laz, and also done close to 300 radio episodes, both in Abuja and Southeast. And through this, it meant that we get a lot of feedback from viewers of our shows and also from listeners. A lot of patients send messages through our communication platforms, and even health workers themselves also get to send those messages seeking interventions. And community work I've got to do through the Make Our Hospital Work campaign. The experience I got through that, I was able to write a book last year on how to make our hospitals work. So having said that, let's move to the next slide so that we could share for that context. Yes, I also follow the 6 building blocks of the health system. Dr. Hamza have already said the ball rolling in that regard from the government perspective. Number 1 is human resource for health, which for me is the most important. Of course, all the blocks are very important. And just last week, I was in my community and I went to a healthcare facility, a PHC, which is the focal primary health facility for my ward. And when I went there, I met a pregnant woman with 2 other persons with her, and they were praying. When we went in with a couple of colleagues, because 3 years ago, I started the Make Our Hospital Work campaign, which is a citizen-led, community-based advocacy. So I went with the secretary of the Make Our Hospital Work campaign, as well as the team lead in my community. So we met them, we asked about the healthcare workers, and they said none of them was on seat. We found out that there are just 2 primary healthcare workers. One was a true, the other one is a true community health extension worker. We waited there for over 20 minutes. None was available. And it's just one. According to the World Health System of the National Primary Healthcare Development Agency, there's supposed to be at least 17 skilled staff in a primary healthcare facility. So you may have a doctor, you may not have a medical doctor, but you have at least 3 or 4 midwives, you have a community health officer, you have CHUs, you have JCHUs, you have pharmacy technician, laboratory technician, you have accounting officer, and you could also have as much as 18 other support staff, which could include account officer, 10 chiefs, it used to be called cops, but now chiefs, who are within the community. So in a fully staffed primary healthcare facility that is meant to operate 24 hours, according to our national policy in Nigeria, we are supposed to have at least 35 staff. So in that, our PAC, we have 2, and they were said to have gone for training, and none was available at the PAC. It just tells this, and this is one of the PACs supported through the Basic Healthcare Provision Fund that is being disbursed on a quarterly basis. So this could be one of the reasons why people are not going, to deliver true skill-based attendance, as already highlighted by Dr. Hamza. And also in my general hospital, I use this as an example because these are practical cases. I'm from Ebonyi State and I live in Abuja. So I assess health facilities. My family members also assess health facilities in these 2 locations. In the general hospital in my community, there's only one medical doctor who was recently deployed from another general hospital. And the general hospital where it's coming from, there is nobody to deploy to that place. And in fact, it was because of the activities of the Make Our Hospital Work campaign that made it impossible for them to leave our general hospital without a medical doctor, because there's an active team in the community that is asking questions, calling the Commissioner for Health, and reaching out to other government persons to make sure that you have staff there. So it's been said that we have less than 10 medical doctors in Ebonyi State in the public sector, and it's been that for a couple of years. So you have one medical doctor who shuttles between 2 general hospitals, located more than, as much as 30 kilometers away. This tells the story of the raging crisis in the human resource. So let me move to healthcare financing. There are so many other examples. You will still move to the next slide. Everything I will be discussing will follow what is on this slide. Healthcare financing. The out-of-pocket health expenditure, Dr. Hamza projected 75%. And good news is that last year, the federal government, Mr. President, gave assent to the National Health Insurance Authority Act, which makes it mandatory, I think section 14, for every resident of Nigeria to be covered by health insurance. So, but how does this play out? We still have 75% of out-of-pocket expenditure. So it's expected that the states, almost all the states, if not all, must by now have a health insurance agency, thanks to National Health Act 2014 that provided for the Basic Healthcare Provision Fund. They had to set those agencies to assess the Basic Healthcare Provision Fund. But what's happening is many of these agencies at the state level are just only focused on assessing the Basic Healthcare Provision Fund, which is grossly inadequate without the state making investments in the health sector. So we have cases from the user perspective where citizens are unable to afford to pay for healthcare. I think 4 months ago, I interviewed a patient with kidney disease at one of the private health facilities in Abuja, whose families have been funding his weekly, I think twice a week dialysis for over a year. So one of them reached out to me and to see if there's a way they could get help, if there's any NGO that gives money to those with kidney challenges. I didn't know of any, but I said, okay, what I could do is put it on TV and perhaps good-spirited Nigerians could help. I went to the dialysis center, interviewed the patients, He said he had lost a wife some years ago, and he doesn't want to die leaving the children alone. He made passionate appeal to the public. Of course, if you watch, 2 more minutes, wow. Okay, so to cut the story short, we made that intervention. Some persons made donations. Unfortunately, a couple of weeks ago, I heard that we lost the patient. He was buried last week. He could have lived if he had up to 15 million naira to do renal transplant, or if he had health insurance that was good enough to cover for that. The patient didn't have that. The man feared death, and he was buried last weekend, leaving the children alone. So these are practical stories of the state of our health system. Let me quickly, the leadership and governance aspect, you have both the community and the, leadership and governance. Sorry, the acronyms I use may not be standard. Community governance system versus government governance system. At the community level, it's majorly for the primary health care. Every village is supposed to have a health committee. Every ward is supposed to have a health committee, ward development committees. Through the Basic Healthcare Provision Fund, many of the ward development committees have been established, but the village development committees or village health committees are largely not existent. These are governance structures that must be in place because they have clear-cut responsibilities. So I'm happy that some communities are already setting this up, but this is required in every community if our primary healthcare must work. Because no matter what the government does, there's something that happened in our health facility in my community. In December 2021, government supplied equipment in the hospital. And as at August, when I took a patient there, I didn't see those equipment. I didn't see the bed, so I raised alarm in the community WhatsApp group. And how did we know that those things were supplied? The Make Our Hospital work team and the village health committee went to the health facility, found out that made a list of everything that was supplied. So with that, people in the community knew. So when I didn't see those things, I asked questions. The hospital management said they've not received any directive to begin to make use of those facilities 8 months after. So we had to put some calls across. Some persons contacted the Commissioner for Health. The next day, the Commissioner for Health came around and directed them to bring out those things and begin to use. So if there's no governance structure at the community level to identify that government made those supplies, brought it to the knowledge of community members, perhaps those things could be there. Before you know it, they start getting missing. And of course, when it was ordered to be made available for use, it wasn't 100% complete. We started hearing stories of some persons borrowed some of the equipment to use. Some health workers had already started taking it to their private facilities to use. So that's, the community governance structures help to be watchdog. We might say civil societies, yes, but you don't have civil societies in every village. So if every village have health committee, that could really help. At the moment, we don't have a lot of it. And a House of Rep member from Kaduna State, I wouldn't mention his name, but he, through his constituency project, got over 20 PACs equipped. And he confessed to me that, when he went back, he didn't win re-election. He went back a couple of years later and discovered that many of those equipment were no longer in those PACs. If we have community governance structures, they could help. So my time is up. Let me borrow additional 1 minute, please. On medical products, vaccine and supplies, as a user, when a patient gets to a health facility and is being given a list of drugs to go outside and buy, it tells the story of poor logistics management system that Dr. Hamza made reference to. So if I have to go by 12 midnight to begin to look for life-saving drugs to buy to be used for me, that could put the life of the patient at risk, especially if there is stock out of that drug, even in the outside pharmacy that is going to buy it. So local vaccine production, local manufacturing of drugs in Nigeria could help to eliminate, to a large extent, stockouts. Health information management system. As a user and as a patient, I care so much about the confidentiality of my information. So sometimes you go to a hospital and you say a folder is missing, and you have to buy a new card. How does the folder get missing? So it's something that as a user, one will be really concerned about. The service delivery, quality versus quantity. If the 5 building blocks are working fine, of course, we should be able to get to a large extent quality healthcare. So, but the quality of healthcare services is much to be desired from my experience. Lastly, a big hospital like National Hospital, denied my wife opportunity to have antenatal care just because she went there with my son, and they clearly told her you can't come here with a child. So, and if such a hospital should not provide, and this happened like say 5-6 years ago thereabout. So if that should happen, then at a big hospital like that, at the city of Abuja, then you may now begin to wonder what could be happening to other places where a mother is denied antenatal services because she came with a child. So many things to fix in our system, and these are just the contents from user and the CSO perspective. Thank you very much for your kind attention.
Thank you so much, Dr. Laz. I'm sure you'll all agree that was quite eye-opening. Some very sad facts and truths coming out there as well. Okay, so we're going to move over now to the selection process for the proposals. We have Dr. Turnwaite Michael. So he's a research consultant at the Development Research and Project Center, DRPC. So they supported the review of the proposal. So he's going to be speaking briefly about the methodology that was used. So please join me in welcoming Dr. Michael.
Once again, greetings to every one of us, our executives and also the participants. I appreciate that we are having you here. Thank you very much. And I want to bring a group from the Executive Director of the Development Research and Project Center that I think my slide should be showing. Thank you. So that we are very much happy and excited to work with the Nigerian Economic Summit group. We are excited working with you. And we also want to add that we want to continue this existing relationship and believing that we're going to make more progress. And before we move on to what we are to do today, I want to just kindly add that the Development Research and Project Center will be more interested in working and also partnering with the Nigerian Economic Summit on issues that has to do with health impact assessment, because we believe that over years, emphasis have been on the process and also even currently on the process. And from rigorous and empirical data review, we have noticed that there is a big gap on aspect of health impact assessment and also what is happening to the vulnerable population at the health facilities, specifically the patients who are in the hospital. We have seen that there's a huge gap there. We are interested in partnering in this aspect to see how we can foster development and health strengthening in Nigeria. Thank you very much. On this note, I wish to quickly move to the Health Policy Commission General Assembly methodology used in selecting proposal for the HPS call for papers on health system strengthening. We are all aware that for those that were selected, there are procedures that were followed. And we all are aware that the selection of this niche requires a rigorous process and a system that won't be biased, to ensure that we have the best that we contribute to strengthen the health system of our nation. Please, on this note, please move to the next slide. And we are all aware of these adverts, specifically those that sent their proposal. They are all aware of this. This was the advert that was released, and the deadline for submission was on this 9th of March 2023. And a lot of people sent in proposal, and those proposals were reviewed, thoroughly reviewed by experts, that includes both consultants and reviewers in academics and also in development space. Please move to the next. So if you look at it, the category of people that submitted the proposals that resulted to the selection of the top best for this commission were all from academia, some from civil society organizations, and NGOs, individuals, the ministries, departments, and agencies, and media organizations, professional associations. They all submitted proposals. And in all, we received the sum of 34 proposals from the public. So after receiving these proposals were thoroughly reviewed, as I said, by independent researchers and consultants. This group of researchers came together and looked at all the submissions. None of them was excluded. Let's move to the next slide. So there were selection criteria that we adopted. The experts and board, they look at it deeply to see where we have loopholes in our health system and what can be done to cover, so that our health policy improvements and reform, we focus on those areas that we have found out that there's a gap that needs to be filled. So when we look at those submissions, we look at it well. This was set up even before our assessment of each of the paper or abstract that was submitted. We look at this, for instance, if you can look at it, we look at it to be ensured that the submission and the selection of each of these should go alongside with the national plans, as well as what is happening at the global and also in our local settings, to ensure the health advancement or development strengthening process is not the one that we will be regretting later. So look at this. From that, we allocated points to each of the selection. For example, 15 points maximum was allocated for submissions areas on the national plans. So what we did was, if you look at the scoring, there's 0 points for any of the proposals that was sent. Anyone that doesn't have that particular first heading, for example, the degree to which the proposal identified relevant barriers to achieving health, delivering/impact. For instance, if a proposal if we were reviewing the process, we notice that none of that point was captured, that person will score 0. Yes, for those people that stated it but not well captured, we can also receive unsatisfactory 1 point. For some others that probably must have captured the point, that is satisfactory, receive 2 points. For those that perform, for the proposal that has outstanding points on that particular segment, receive 3 points. So this was how we did for each of these, for the proposal submitted. For instance, if you look at the second one, the degree to which the proposal addresses building blocks of health system. If you look at it deeply, some of the presenters, the first, the third, second and third, even the first, emphasis has been on that health building blocks, such as the service delivering health workforce, health information system, access to essential medicine, health financing and leadership and governance. So those proposals that have each of these or any of those elements were also awarded. Then we also have other ones like the degree to which the proposal is crucial to achieving the health-related sustainable development goals in Nigeria. We also look at these proposals that touch that aspect were also given grade. So some of them that are here, each of them, I believe they must have seen some of the aspects to which their work were also examined. And I must be sincere with you that we don't know those people that were selected. When the process was ongoing, go back to the first slide, let's be sure. Let me show you something, please. No, the slide before this, please. Before this, can you go back, please? And you can see that that was the only thing that was given, title of submission, and also topic of proposal. So we don't know the names of those who submitted, we don't know the organization. So that was what we received. So that was what we used for the assessment. So it's today that I may be privileged to know who and who emerges winner. We don't even know. And all the other reviewers too, they don't know. So that was how we did the process. So let's go to the next one now. So we also look at methodology because some people presented good points, but we also want to find out that to what extent is the method they employ or they are planning to employ in the process workable. For example, the proposal uses a sound methodology for achieving the stated outcome. So if it has, then we awarded mark to it. If it doesn't, receive 0 or 1 or 2. Then, or probably if it has little, 1 or 2. The proposal outlined how it will address or impact on the underserved health system in Nigeria. We also awarded. The proposal described the types of deliverable to be provided to achieve the overall goal of universal health coverage. Was it there? So it was also received mark. The implementation process too was also considered because some of the proposals, some of the suggestions may have been very important, but the achievement of its, feasibility of its achievement were a problem to some. So we also look at it, the points and the suggestion made. Is it something we can achieve in short or long-term goals? Or project pursuits. So we look at this, the degree to which the proposal is cost-effective and leverage health system financing to promote the universal health coverage, where sufficient funds for health are available to ensure services do not place severe financial hardship on the client or the patients. So something like also the degree to which the proposal promotes new and innovative approaches to health system delivering. So we're also looking at something new that can also see how we can promote our health system of our nation. So we also look at the degree to which applicants has demonstrated experience and knowledge also in achieving this goal which they have stated in their proposals. So we also look at it, if you remember the submission, the page which was showed at first, it was indicated there that the submission should be between 150 to 200 words. Some of the proposals were within those words, some were more than those. So for those who were more than that, or less than 150, some were even 300, 400, they all received 0 on that particular lens. So those who met the 150 to 200 received 1 point. So in all, they were supposed to receive 34 points. So at the end of it all, those who came up at the top were those that were selected and submitted to the boards. And which boards also had to confirm, because all the names, including those, all the 34, including those who were topped and those below, all the gradings were all packaged together and sent to the board. We also look at it to ensure that it's aligned with the selection process. So I want to congratulate those who have been selected for this process, because the rigorous stages which it passed through, I must tell you that they sincerely deserved applause. So at this moment, I want to say thank you very much for your time and for listening.
Thank you very much, Dr. Michael, for highlighting the independent and robust nature of the methodology that was used. Okay, so now to one of our main events of the day. So the presenters are going to be coming up to present their work. So do we have the PowerPoint of their profiles? Can we just put that on the screen? So we have Mrs. Paulina Akanet. So can we have the PowerPoint presentation of their profiles first so that we can introduce them properly? Okay, so we have Mrs. Paulina Akanet. She's the State Program Manager, SMGL Project Nigeria, Pathfinder International. Then we have Mr. Olalekan Ramon, Senior Project Lead, Insight Health Consulting Limited. Dr. Jesu Pelumi Adenihu, she's the COO, co-founder of MyChecker. Dr. Nkechi Asogwa, Director, Doctors Health Initiative. And then we have finally Ms. Olukorede Oreoluwa, who is a doctor in training. So those are our 5 presenters for today. So we'll kick off with Mrs. Paulina Akanet. Welcome, Ma. Thank you very much for joining us today, and we all look forward to your presentation.
Thank you so much. Okay.
Welcome.
Good afternoon, everyone. Can you hear me? Okay. I hope you can all hear me, right?
Yes, we can.
On. Okay, thank you so much. So as rightly stated, my name is Paulina Akanet and I work with Pathfinder International. I'm here today to present our learnings in working with the private sector in the field of reproductive, maternal and newborn health that we are implementing here in Kaduna. Next slide, please. Okay, as a background information, I think the previous presenters, especially the Executive Secretary for Kaduna State Primary Healthcare Agency, had already given a brief background about the private sector. We know that they play a very huge role in ensuring that our women and our children receive care. And based on data available, we have at least about 40% of services across reproductive and maternal health issues that are presented by the private sector. So it is quite imperative for us then to strengthen their participation through private sector policies, to also look at governance, supply chain management, health information, finance, and especially health resources. All of these strengthening will help health outcomes for our mothers, even as they continue to seek care from them. Pathfinder International is implementing this project that is known as Saving Mothers Giving Life, and that is what SMGL 2.0 is. 2.0 is because we had implemented same activity in Cross Rivers, and we're implementing the second phase. And the project interventions, was aimed at addressing the 3 delays. And I will just recap the 3 delays. Thankfully, Dr. Hamza also talked about that. We have delay. The first delay that occurs in the community, it's either because the family does not recognize the problem, or they take a long time in deciding to seek care. The second delay is now reaching the facility itself. And the third delay is also now getting to the facility, receiving adequate care that will save the woman from any complications. Next slide, please. So for Pathfinder International, what we did was our approach was multi-pronged, meaning that we did not just pick one area of intervention. So the first approach is we looked at the collaboration between the private sector and government, and we were able to continuously, we did continuous strategic stakeholder engagement so that the 2 sides can listen to each other and also work together. So we were able to create a platform for collaborative decision-making. I think as an example, we will continue from there and we'll see examples as we continue. For capacity building activities, we're implementing these activities in 25 private facilities. And so our capacity building was around these 25 facilities. We trained doctors, nurses, midwives, choose on emergency obstetric care, on essential newborn care, family planning, and also M&E. These are some of the activities that we were able to build their capacities on. We also instituted mechanisms for quality improvement, and we set up for each of these private facilities the maternal and perinatal death surveillance response committees that are now reporting to the state committee on all the deaths that occur within their facilities. We also attended to demand creation activities where we leveraged on existing structures in the community, like the Ward Development Committee members, traditional birth attendants, and the patent medicine vendors, where we worked with them. We improved their capacity on the knowledge of danger signs, how they can mobilize women and their children, and then refer them also to the hospital so that they can receive care. And then finally, what we did was digital health intervention. We collaborated with a digital health company that is called NEVI. And what we did with them was we set up a WhatsApp platform, digital information, where all of our women can onboard both at the community level and at the facility level to receive content and information on their pregnancy journey, delivery, and antenatal delivery, family planning, immunization, and also postnatal care. All of those informations were information that were sent to the women as the need arises. Next slide, please. So, okay, in a nutshell, those are the activities we implemented. But for us, our outcomes, one of the things we understood is the fact that we needed to continuously advocate and engage the ministries of health so that we can achieve that synergy between the two bodies. And so some of our achievements or activities was we were able to have the private sector, especially the associations, included in most of the maternal and newborn health forums, like the technical working group activity meetings, so that they can also lend their voice. We were also able to work with the private facilities so that some of them were empaneled into the state insurance scheme so that we can reduce out-of-pocket expenses. And we also improved their skills on data reporting, and that was also something that was an achievement for us. Next slide, please. So on the issues of activities that we did, please note that most of these results are facility-based results. It's not about Kaduna State as a whole. So based on the facilities and the baseline assessment we had carried, we had reduced for these 2 years that we have implemented 75% reduction in maternal mortality, 13% in perinatal mortality. And because of the capacity building activities, we now have 100% deliveries attended by skilled birth attendants. And also we've seen a 65% increase in mothers who receive postnatal care from these 25 supported facilities. Thank you very much. And I hand you over back to the center.
Thank you so much, Mrs. Akanet, for your presentation. That was very interesting and insightful. So we'll just formally introduce our presenters, if we have those slides. Okay, so if we don't, maybe I'll do that at the end, just to give an opportunity for us to know them a bit better. So we'll go over to Mr. Olalekan Ramon. I believe he's in the building. Fantastic. So we'll go over to, so he's the Senior Project Lead, Insight Health Consulting.
Thank you very much. Good afternoon, everyone. Yes, my name is Olalekan Ramon, representing Insight Health Consulting, and I'm here with two of my colleagues in persons of Mubarak Ahmed and Bolaji Akala. Before I continue, I'd like to thank NESG for giving us this opportunity to make this presentation. Okay, so I'll be talking on upskilling and improving the National Health Workforce Registry. Dr. Amza and Dr. Laz had spoken about a very important component of the health system, which is the health workforce. And we can all agree, even from the events around us in the recent years, personal events, and even from evidence in the reports that we've read, that indeed HRH is a crisis that requires a local imperative that the government and the partners need to do something about. Next slide, please. Next slide. Okay, so I'll just touch briefly on this, who we are. Insight Health Consulting Limited is a public health consulting firm. We've been around for about 2 decades, and we are into research, we're into program planning, population analysis, health system strengthening, and providing technical support for partners and programs in Nigeria and some parts of Africa. Next slide, please. Next slide. Okay, so I'd like to ask us, how many health workers do we have in Nigeria? Does anyone know? How many nurses do we have in Nigeria? How many pharmacists? How many pharmacist technicians do we have in Nigeria? So this underscores a need, or there is a need for us to get the actual number of health workers that are available in Nigeria for the singular purpose, or for the very important purpose of planning and resource allocation. Okay, so some background about this issue. The health workforce, is one of the building blocks of the health system. I've said that before, and it is one of the primary issues confronting the global health system is the shortage of human resources for health. And Nigeria, as one of the low and middle income countries, is disproportionately affected for a lot of reasons. The HRH shortage is due to a lot of reasons, which include low or inadequate capacity, also the immigration of skilled health workers. We've heard about the Japa syndrome, which, as years go by, is beginning to deepen. I can say of about 3 of my colleagues and friends who have moved, and I know that you know someone who knows someone that has moved out of the country, and it doesn't appear that that trend is going to stop anytime. We also have the problem of low funding and inadequate planning. So evidence suggests that we have about 0.4 physicians per 1,000 population. That is the physician density that we have in Nigeria, and also 1.48 nurses, okay, which is below the WHO recommendation of 2.3 skilled health workers per 1,000 population. So we can see that this highlights the debt and the shortage of HRH. Next slide, please. Okay, so to address this challenge, WHO has recommended that there should be evidence-based policy development, okay? Also effective governance and leadership, better data on human resources for health or health workforce, and also investment into HRH. But several African countries have the challenge of collecting, analyzing data, especially in terms of HRA. So WHO also further recommends establishing the health workforce registries, and there have been reports that the establishment of these registries have yielded good results in countries like Cote d'Ivoire and Kenya. Next slide, please. Okay, so what about Nigeria? So Nigeria also has a health workforce registry, okay? But the journey started in 2013. That's about 11 years ago. Well, we can see that we have made giant strides, but there still needs to be improvement, okay? So in 2013, that was when the commencement of the registry began. And afterwards, support from the likes of Canada, Plan International, and WHO ensured that there was the development of the prototype, okay, which was on Iris Manage. It's a web-based platform that hosts the HRH, management software. Okay, so as of 2021, what we have is a compendium of various SOPs, implementation guidelines, and documents that allows the decentralization of this HRH to other states in Nigeria. So presently, next slide please. Presently, we just have about 11 states in Nigeria that has registries, or we have 11 states that are recorded on the national registry. So that represents about just 30% of all the states and the FCT. Next slide, please. Okay, so this highlights where and how the registry sits in the whole scheme of things. So the registry is an important component of the HRH information system, okay? So we can see that, in the HRH information system, we have the workforce registry, all right? So WHO had recommended that to have a workforce registry, you just need a minimum of 10 data points or 10 data sets. Very simple and very easy. And these are the ones listed here. We have birth history, your name, your location, and so on and so forth. Next slide, please. Okay, so this further highlights the distribution of the states that have been included in the national registry. We can see that it's quite disproportionate, although these states were selected, purposively due to a lot of reasons, one of which is funding constraints. Others were because states were selected for, piloting. But in all, we have 11 states. And then we have just about 89,000 health workers who have been captured on the registry. And a recent report by WHO lets us know that we have about 940,023 health workers in Nigeria. So you can see that we still have a lot of health workers who are yet to be captured. And even that figure is not an exact figure, it's just an extrapolation based on, surveys. Next slide, please. Okay, so the objective of this proposal are to assess the registry to inform modification in functionality, in operation, data accessibility, and data sharing, to strengthen the governance structure, and also to scale up to national coverage. Next slide, please. Okay, so our approach encompasses 4 stages, which are stakeholder engagement, review of the national HWR data, assessment of the governance structure, planning of the scale-up and implementation in phases. So we know that for projects now in Nigeria to be sustainable, we need to strategically engage our stakeholders so that they can take ownership, right? We will not just go and say, this is what we want to do. We want to ensure that it aligns with your own, strategic plans, right? So that will be putting them, in the driver's seat. So the next thing is to review the National Health Workforce Registry data. So because WHO has given us, all that needs to be as minimum data in the registry, we want to be sure that indeed that the registry complies with, all of this minimum data set. And if they don't, what are the issues? Do they have issues in gathering data at the state level? Maybe probably from the private sector or the public sector. Next slide, please. Next slide. Oh, hold on, please go back to the previous slide. Okay, so already the HWR has some things in place, which is the governance structure, which is made up of a steering committee, and is also made up of the Health Data Governance Council and the Health Data Consultative Committee. So these are the three major elements that make up the governance structure for the HWR. Okay. So what we want to do after this is to now assess the governance structure to see what the challenges they are facing with the HWR in ensuring that the operationalization is full. What are the challenges they are facing at the state level? What are the coordination challenges also that they are facing? Next slide, please. Okay, so in assessing the national registry, we'll be focusing on some elements, which are the data. So we'd like to know, does the data and the registry comply with the minimum data set? We also will be looking at the data collection and management system, okay? Can the software handle large volumes of data? Do they have problems with interoperability? We know that the IRIS Manage, is supported by WHO, and it doesn't seem to have that, but we want to know in practice with the FMOH and those who act as the governance council, if they're having problems with the platform. Also, the reporting and analytics, do they have a dashboard representation of the data that has been collected? And user management and access control. Why, for example, is the data not available to the public? Or maybe not all the data, but some part of the data. If you look at the registry of some states in developed countries, right, you punch in a name, it gives you their license number, the hospital where they work, right, and just a few other information, but not all the information. So we believe that these kinds of information should be available to the public. Also, we'd like to assess the registry at the state level where the actual data collection occurs. At the federal level, that's a collation center, and they just analyze, ensure data quality, right? But at the state level, that is the place where the actual data collection, occurs. So we want to know what challenges they are facing in collecting, data at the state level. So we'll be assessing about 2 state level registries also. Next slide, please. All right, so in strengthening the governance structure, of course, we would conduct key informal interviews with them to know what the experience of use is, to know the coordination challenges, especially integration of the private sector, okay? And also, recommendations for improvement. And also to identify duplications, and recommend reassignment as appropriate. Next slide, please. I have to rush now. Okay, I had mentioned this. We have just 11 states that are recorded on the registry. So our plan is to support the establishment of a steering committee in 25 other states and the FCT, and also to facilitate the training of the operational team using a handbook. A handbook has been developed already that ensures sustainability, so we don't need to reinvent, the wheel. And also to provide technical assistance for the rollout. Next slide, please. Okay, so this framework was developed during the implementation phase for the 11 states. So we'll be following just exactly as it's been laid out. Next slide, please. Okay, so we're able to identify some barriers through preliminary, SWOT analysis, and we believe that with some of these strategies listed here, we'll be able to achieve, we'll be able to achieve integration of all the data for all the states in the registries. Okay, we'll also be able to make some data available, to the public. And at the end, we expect that there will be improved HRH planning and decision making at the federal level, and also improved health outcomes. Okay, so we envisage that, next slide please, we envisage that this support will take between 3 and 5 years. The 3 years for the first phase of scaling up to about 13 states, another 1 year, 2 years to the next 13 states, and then the last year for monitoring and evaluation. Next slide, please. Okay, so like I've said before, Inside Health Consulting has been in this business for over about 2 decades, and we are well versed, with what the HMIS or the Health Information System entail. Okay, we understand that there is always a need to use a comprehensive report, so we have access, controlled access to some of this data, and we're able to, provide evidence-based for planning and decision-making as recommendations to partners and government institutions. Next slide, please. Next slide. Next slide. Okay, thank you.
Thank you so much, Mr. Olalekan from Inside Health Consulting. Okay, so we're going to move over now to Dr. Jesupelumi Adenihun. She's the COO, co-founder of MyChecker. I believe she's here with us physically. Please join me in welcoming Dr. Jesupelumi, please. Welcome. Thank you.
Let's come with my phone so I can just time myself. Good afternoon, distinguished guests. I'm delighted to be here today, and I think it's a great honor to be speaking to every one of us. So I'd be speaking very briefly, and I'll do my best to, stay within the confines of the time that has been given to us. Next slide, please. Yes, so I'm Dr. Jesupelumi Adenihun. Most times when people want to call my name, they say Dr. Pelumi, like if I meet them outside, but I'd rather be called Dr. JP if they're not calling the full name. Yes. Thank you. So I'm the COO and co-founder of Checker. Checker is a digital health platform helping people access diagnostic tests from the comfort of their homes. So just like Uber, but for healthcare, and that's what we're building across Africa, starting from Nigeria. All right then, so please can we go to the next slide? Yes, this is the outline I'll be following. By way of definition, just a brief, I know we all have an idea of this, but health system comprises of organizations, institutions, and then resources, elements that are devoted to producing health actions. And then health system strengthening comprises the strategies, responses, and activities that are designed to sustainably improve country health system performance. So in the illustration there, that image has, the building blocks But for me, like, I'll be focusing on the health workforce, and I'm thankful that Mr. Rahman also touched on that. He sort of made my work easier, and I know we're even familiar with the problems that healthcare faces, even in this part of the world. But interestingly, it's not peculiar to Nigeria. So initially, I thought the problem was, Nigeria or Africa lacks the health workforce. But then it has happened that there's also the deficiency in the Western world, but they are making use of our human resource to fill in the gap that they have. So it's a global problem, and for us, we have that the current estimate is that it's one doctor to about 9,000 patients, and when the standard should be 1 to about 600, but this is the scenario that we have here. Nigeria's current picture says to be maybe about 24,000 doctors. I'm just maybe permits me to be biased towards why I'm focusing on doctors, maybe because I'm one. But beyond that, if we even consider like the other workers in the healthcare space as well, we'll see that there's a huge gap, just like Mr. Ramon had mentioned. And then the current graduating capacity. So we'll see why I'm talking about this, because I'm going to speak on the national level and then even how like the solutions that can be or can be adopted, yes, at the other levels. So Nigeria's current graduating capacity, about 3,000 plus, still like 3,530, most recent data that was released. And then when we get other, foreign students coming, about 1,000 of them. And if we look at this, so maybe annually, we're saying we're adding 4,000, 5,000 doctors. And if we're looking at it, we have one ratio, 9,083 patients. If we need more doctors, say, the last estimate that was done said we need about 363,000 doctors for us to say that we can actually achieve our standard ratio. And that's a long haul. So even with the solutions that I prefer now, we'll see that it's still long term. There are things that we can do in the immediate, but there are also things that we need to know that, okay, this is a long journey. Okay, so what are the reasons for this exit? Just like it has been echoed over and over again, there's inadequate infrastructure, there's unfriendly training environments, insufficient jobs for medical graduates, poor welfare, low incentivization, inadequate medical training schools. So the crux of this, or the basis, is that we don't have enough workforce, and we can look at it from different angles. So it can be from the angle of training, it can be from the angle of during, like, say they've completed their training processes and then they're now working, and then post. So what happens after they've been trained? Well, I'd like us to look at this medical training schools. So I know that we have medical schools in Nigeria, and thankfully, even though it's said that our medical education system, that there are issues with our system, the truth is we still produce resources that are being used in other parts of the world. But can we maximize what it is that we have now and say that, okay, so we have more private institutions that are coming on board, we have more private universities, and the last data that I saw recorded was that we have about 111 private universities. Sorry, that should be 7, not 17. And then 7 medical schools from the private sector. So I'd ask it as a question, because I want us to, always also have this at the forefront and then even continue to think of it as well. So is it possible that these private institutions can make use of the existing infrastructure that the government has, and then say with their own facilities, the government facilities, investment is poured into what's the government infrastructure, and then students are trained even in these medical schools. So we have more medical schools that are possibly graduating more students, and then hopefully, hopefully, we're able to have more hands just by that public-private partnership, that there's a collaboration between our general hospitals. Like, we have so many patients that go in and then flood those places, and then a private institution saying that, okay, I don't have to build from scratch. Like, I don't have to wait till all of the infrastructure is available. There are already hospitals that we can just partner with and then see that this is what is used to channel the learning processes for our students. And then active promotion of exchange programs. I don't know why, but I don't think Nigeria has harnessed this. So for me, I finished from College of Medicine, University of Lagos, proudly, and Thank you, ma. And I mean, I remember during 500 level, so we went for elective programs, and elective are the exchange programs. You get to go to other universities and then see what is done there. And you pay, like we pay for it. We pay and then you get there as well. You also pay, like you're contributing to the economy in one way or the other. And for us here, most of them over there see Nigeria, or should I say Africa, as a project in the sense that, they hear about us and they're like, oh, these countries, some even still think they're like we're maybe monkeys, maybe not as bad as it used to be, but some still have that mindset. And then it has to be that we're now pushing it as part of the metrics that each university is being assessed on. So what is the level, or what is the amount of exchange students or foreign students that are coming in? And they pay for it. Like, we can generate, let me use the word, but we can generate revenue and economic returns from that, from the university. Let students come in from other parts of the world. Let them experience what healthcare in Africa is. I've heard people say things, because we get to converse with our colleagues that are, have gone, well, for those of us that still seem like the crazy ones that are here anyway. But yeah, we get to converse with them and they say things like, oh, I hear of interesting cases that you have in Nigeria or in Africa. They don't really have cases there, or maybe something like even the emergency, they really want to experience what it is that we have here. So it's something that we can actually harness, and the only thing that is just required is bringing it up to, should I say, the standard, and they're just pushing it that, okay, so at the university level, I'm saying let me use my alma mater for example now, and say that they are now actively pushing it out, just the way other universities will push out their MBA programs, or say they're pushing out their own elective programs. So my own university as well is also having something on YouTube. I know these things, maybe because I'm in the tech space as well, like I want to see things like this, like, also being incorporated in our health space and even in schools. So I'm seeing something come up on top of my phone, say that, come for programs in Africa or in Nigeria. We beautify these things. We have the resources, and we can maximize what it is that we have, even with these exchange programs. And even beyond the economic gains that will be brought in, I also know that some of these people would want to come back and then even practice. And for foreign trained students that come after they're done with their learning, it can also be an avenue for them to come in just before they're even done with school. Yes, and then, so yes, harness the existing human capital. Sorry, let me just pick on that third one. Let me see. I've done 2-3 minutes. Yes, the existing human capital. So something that we've done at my organization at Checker is, we more or less like easing off the burden of work, like even for hospitals, and then just trying to reduce the traffic that happens in laboratories. And recently I came across a colleague, so she's also a doctor, and then what is being done is that people are being trained even to have skills like, phlebotomy. They don't have to go to school for another 6 years or 4 years, 3 years for them to be able to take certain samples. They're licensed, and then they go through that training. It's done within a short time, and they can take off that burden of saying, say in the hospital now, a doctor, even though they have the skill, like, it's not what they should be focusing on. They should be focusing on more specialized tasks, or more specialized tasks. So in our institutions, that's something that we're already working on, even with at the federal level, like with certain hospitals, like they take off that burden of work from the doctors or even other health workers. Just encourage task shifting. And then I'll go to the last one quickly, adopt telehealth in primary care. So we know telehealth to be the virtual consultations and all of that. But yes, I think it was Mrs. Paulina that mentioned how there's a WhatsApp group. And even though that thing seems very basic, I found it excellent that they're just communicating to patients, pregnant people, about what they should do just on WhatsApp. That's adopting technology as well. And for us now, so we're thinking on a global scale. So how can we use USSD to, make healthcare checks or even consultations available to every Nigerian, like in the 36 states that we have? And that's the approach. Like, those are the things that we are working on our own end. Yes, so, okay. Next slide, because not everyone has to go to the hospitals or present even to the tertiary facilities. Yeah, so I'll just go over this quickly. So just what are the next things that we can do? Like, review the policies that are governing training of medical students, draw proposals of investment opportunity when we talk about, the private and the public partnership to train more people. Then map out existing facilities intended for the purposes, universities to have the exchange programs, identify areas that we can make use of the tax shifting, and then even for us, how we can, partner on this level as well. And then possible outcomes. Last slide, please. The last slide. So, the possible outcomes that we have, increased workforce, increased number of healthcare workers that are trained and are even available to help with our health system. Then there's increased economic gain, inflow of health workers, improved patient outcomes. And I'm sure that the list is numerous, but just felt to leave it to that. So I know that the journey to achieving the health system that we desire is a long haul. But these are things that, even for those of us like in the technological space, or I'm in the technological space, there are things that we've started working on. And it's for us to now say, okay, we're putting our hands together with the government and then seeing that we spread and multiply the effect of our services across our nation and even spread into Africa. So the last slide, I'll just conclude with this quotes. Last slide, please. So it says, pioneering spirit should continue not to conquer the planet or space, but rather to improve the quality of life. And I believe that whatever solutions it is that we're bringing about are probably solutions that are being pioneered for the first time. But I trust that we can make Nigeria great, and we're grateful as well. Thank you so much.
Thank you so much, Dr. Jesu Pelumi, or Dr. JP. So for your PPP model for medical education, thank you very much. Okay, so we're going to move over to Dr. Nkechi Asogwa, Director, Doctors Health Initiative. I believe she's joining us online. Oh, there she is. Good afternoon, madam. I hope you can hear us.
Yes, I can. I hope you can hear me. Good afternoon.
Yes, we can. Good afternoon, ma. Over to you.
Good afternoon, everyone, and I stand on the existing protocol. It is indeed an honor and a privilege to present to you this afternoon, and I thank the Nigerian Economic Summit Group for giving me the platform to do so. We just heard from the previous speakers, and I think they've made my job a lot easier because all the background information we needed are there. So I am the president of Doctors Health Initiative, which is a not-for-profit organization based in Lagos. And one of our objectives is to provide quality health care to underserved communities, not just in Lagos, but across the country. Now we've heard Dr. Laz, who spoke about the man who died from kidney disease. This is a common story across the nation. And a study by Lancet says that about 6 million deaths occur annually in developing countries from low quality health care. And Nigeria is not exempted, as we have seen from all the previous speakers. Now, universal health coverage means providing access to quality health care for all citizens, while ensuring that access to health care does not lead to financial catastrophe for individuals and families. Therefore, our own proposal focuses on robust financing as a component of health systems strengthening. And as we've seen from other speakers before me, this component is very weak in Nigeria. If our budget is only 5% for health, it means that roughly 75 to 90% are out-of-pocket expenditure. And that's a huge amount for quite a lot of the population. And therefore, we're not surprised about the death toll that we're being told. Please, next slide. So our proposal is community health insurance model, which has as its motto, affordable and accessible health to all. So that goes into what universal health coverage is attempting to achieve. And the principle, please move on to the next slide, of the community health insurance we're trying to propose here is that we want to involve natural communities as part of the financing of healthcare. How do we achieve that? I liked what Dr. Patrick had just said in his opening remarks. He said, we're talking about health, not health for all, but health, not just health for all, but health by all. So here we're trying to involve the communities in healthcare financing, in kind of financial protection, where they are in the front seat of making sure that this universal health coverage, that they're involved in it. So what our proposal looks at is that the overhead is very low because the premium is going to be collected by the community leader or the head of the group. So the natural communities we're talking about are communities like savings group, the famous Isusu groups. You have church groups, parent teachers association. In some communities, you have burial groups. So these are similar communities with similar health challenges. So it's easier, more or less, to work with such groups if they can be made to understand that they have a key role to play in that. At first sight, this might appear to be naive because no health screening is done. There's an assumption here, and that assumption is that the majority of the clients or the patients should have good health. But when this model has been used and it has been put in place in some countries in Africa, they have achieved a better health coverage for the community because of having their buy-in in that. And then the premium usually is for covering of acute medical and dental cases. It doesn't include chronic illnesses or regular drug that the patients collect on a regular basis because of chronic illnesses, because that will make the premium to go very high and will probably make sure that a good number of the people are not part of the scheme. So another thing that makes our proposal very affordable and workable is that it builds on existing structures. We don't need to look for things outside what the community already has in place for it to work. So, but this will only work on if some key principles are taken into account, and that's what you have on the screen there. First of all, trust. Trust that the healthcare provider have their back covered, that the community must trust the healthcare providers. Again, I'm referring to Dr. Laz's story about going to a primary healthcare center and having to look for the health professionals that are supposedly in charge of it. That cannot happen, because if that happens, then the community will lose trust in the healthcare provider. And then that also leads to, if there is trust, the community also understands that the healthcare provider is motivated by service and not just financial motivation. And then together, the community will now feel the need to be the motor, the drivers. The ownership of the scheme belongs to them. Now, for that to happen, one way we have seen that this works is getting the group leaders or heads to sit with the hospital or the clinic heads, where you have a dialogue, a kind of an annual general meeting, sharing inputs and seeing the way forward. Now, if the group heads or the community leaders are the ones collecting the premium, they need to be the strong link between the healthcare provider and the community. So in that case, the trust issue is also very much is high, because they are part of what is happening in the community. They are also part of ideas, suggestions to the healthcare provider. So we get the community to buy in, to own the scheme. And in that way, they see the need to maintain a certain level of health. Because if the health care is raised to a high standard, then we'll have less need of admissions, less need of medical expenditures that we could have cut from the beginning. So together, both the healthcare provider and the scheme we're talking about and the community walk the road to affordable access to quality healthcare, which is where this proposal is heading to. So again, there's a financial protection of the community led by the community together with the healthcare provider. So what are the outcomes where this model has been used? First of all, there is an improved uptake of preventive medicine interventions among those in the scheme. So if there is an improved uptake, it means that we have less admission, the admission rates will drop, and then the scheme will yield more in that respect. And then in some communities, what has been done is also to involve artificial intelligence. I'm glad the last doctor talked about using telemedicine. So using artificial intelligence systems or apps that will make it easier to have an analysis on the go of what is going on in each community. As I said before, when you have natural communities, their health challenges tend to be the same. So if, for example, we have an analysis and we realize that from this particular community to have high cases of gastroenteritis among the children, one can do several things. One is identify, why are we having this in this community? Could it be their water sources and so on? And if that's the case, we need health education, we need to treat them and so on. And in that case, we already catch that infection on time before it spreads. So really, this model is something that could be easily implemented and will yield a lot of good for the community, and in the long term will strengthen our healthcare system as we know it at the moment. So together we'll achieve the universal health coverage, which truly is possible even in Nigeria. So thank you for listening to me.
Thank you so much, Dr. Nkechi Asogwa, Director, Doctors Health Initiative, on your community-based proposal for health system strengthening. Thank you so much, Ma. Okay, so now we'll move over to Ms. Olukorede Oreoluwa, I believe soon to be doctor. She's a doctor in training. So Ms. Olukorede Oreoluwa, please do come over. Please join me in welcoming her.
Hi, everyone. Excuse me. My name is Oreoluwa Olukorede. Sorry, I don't do well with cold. So. Thank you. I'm a doctor in training and from Beta Wi-Fi University, and I'm a boarding health economist. I hope that someday I would be able to join this amazing group and the Health Policy Commission. So just a quick question. How many of us here have actually used a primary healthcare center? Have we ever walked into a primary healthcare center to get help? Medical service? Okay. What of private hospitals and even teaching hospitals? How many of us here? Yeah, almost everybody. So I realized that the only time I stepped into a primary healthcare center was during a community medicine posting, and it was compulsory for us. And I realized that there was no healthcare worker in the primary healthcare center. It was just the local government representative. And a nurse goes to that place every week, every Thursdays, which is really, really sad. So I'll be speaking on upscaling primary healthcare financing for universal health coverage. So just a quick background information on the current healthcare system we have, which is a decentralized system whereby each level or each tier of government caters to different healthcare systems that we have, starting from the primary healthcare system, which caters to minor illnesses like malaria, allergies, flu. And according to the Alma Ata Declaration of 1978, it was said that this healthcare system is in charge or is the key to achieving universal health coverage. So when we have a primary healthcare system that is a failed one, we cannot achieve universal health coverage. Excuse me. Moving on to the secondary healthcare system. This system caters for minimal complex cases, and the tertiary healthcare system caters for mostly advanced cases. But most times when we have malaria, flu or what have you, we go to the tertiary healthcare system and we skip the primary and secondary healthcare system altogether. This shows that there is a systemic problem that we need to address. And this problem stems from, thank you. This problem stems from a failed primary healthcare system. So moving on. Can you change the slide, please? Yes. So to look at the funding of this system, the Basic Healthcare Provision Fund was established in 2014 to cater to three main gateways: the National Health Insurance Scheme, which is now National Health Insurance Authority, the National Emergency Treatment Service, and now the National Primary Healthcare Development Agency. And this agency is in charge of the primary healthcare system. So this Basic Healthcare Provision Fund is funded by three main mechanisms, starting from 1% of the Consolidated Revenue Fund, and then through the private sector's involvement, and also from grants from international or foreign agencies. So we've seen that over the years, we have not been able to achieve 1% meant for this Basic Healthcare Provision Fund. From 2018 down to 2020, we've seen a downward spiral from 0.56% to 0.42%. Sorry. So we've seen that when there's a funding issue, the problem goes, things spiral downwards. It causes a ripple effect of problems, from healthcare workers not being motivated enough to work, to the health facilities being abandoned, and then overall it leads to poor service delivery. So what can we do to upscale the key to achieving universal health coverage? It's a very important issue that needs to be looked into. And the federal government is the main driver of this change that we are seeking for. Funding of the Basic Healthcare Provision Fund should increase from 1% to 2%. Now we have 0.48%. COVID even made it worse, so we have less than that. So this is going to increase significantly the funds that are being directed into the primary healthcare system. The state government is not left out too. The state government should also increase the counterpart funding from 25% to 30% as a prerequisite for accessing the Basic Healthcare Provision Fund. Other mechanisms should be looked into too by the government, from tax from potentially harmful products like tobacco, alcohol, even sugar-sweetened beverages. These are called sin taxes. So we should direct it to the primary healthcare system, because most times when people fall ill from consuming these products, they have to get healthcare from the nearest place to them, which is the primary healthcare system. Yeah, so moving on, our foreign donors have been super generous. Different grants, aids that have been directed towards different diseases intervention and programs. But it would be also important or very beneficial to the primary healthcare system if a particular percentage of the grants or the aids are being directed to first strengthening the system, and then the other half towards addressing a particular disease. Take HIV, for example. After these grants are being exhausted, people that have HIV or people living with HIV cannot get or cannot continue management because the healthcare center closest to them probably doesn't have medications or they can't afford it. So it shows that there's a problem that needs to be addressed by our foreign donors. Moving to the private sector. Sorry. Yes. Moving to the private sector, they've been super generous with so many initiatives like the Adopt a Healthcare initiative, whereby they are trying to refurbish all primary healthcare centers in 774 local governments. So we need more initiatives like that. We need philanthropists, even the private sector body can dedicate a particular percentage of the annual profit towards our primary healthcare system. And I believe that this is going to go a long way towards financing the primary healthcare system. Just to wrap things up, in conclusion, upscaling primary healthcare financing or the system generally is an effort that requires joint hands from the government, like I said earlier, to the private sector, and also to international donors, and even we, the population, we, the users of these facilities. So it's important that we demand accountability and from the primary healthcare bodies and even our local government subcommittees, and also the government should show strong political will through adequate funding. Let it not be something on paper. We need to see work being done. And also healthcare workers too should try to support the healthcare system by carefully utilizing the resources, the funding that is going to be provided, and ensure that adequate service is being delivered. So, next slide. Yeah, so we are planning to take the primary healthcare system for primary healthcare facilities from before. This is what you see when you walk into some PHC centers, especially in rural areas. So we are taking it from before to after, and I believe that is possible through joint efforts. Thank you for listening.
Thank you so much, Ms. Olu Korede Oreoluwa, for powering through despite your voice. Okay, so we will now have some remarks from Dr. Laz and Dr. Hamza. Apologies, Dr. Francis has not been able to join us due to some last-minute changes in his schedule. So we'll have some comments from we'll start with Dr. Laz, and then Dr. Hamza can just give any remarks or comments on the presentations that we've just heard so far. So Dr. Laz, he's already online. Oh, Doctor. Oh, yes, so if Dr. Laz is online, she'll be speaking after this. So.
Yeah. Okay, thank you very much. Very brilliant presentations, and I like the fact that it was taken from different angles, from Pathfinder International, a non-governmental organization doing tremendous job in communities, especially in the area of family planning on health system strengthening. It was good to know the work they are doing in Kaduna State and some other parts of the country. Also, the National Health Workforce Registry, fantastic initiative. When he asked the question on how many health workers in Nigeria, I asked myself, do I even know the exact number of medical doctors in Nigeria or community health extension workers? It will be very good to have this data because now the new administration is coming in. Those data is required to kind of do some gap analysis using real data by advocates who might be pushing for engagement of more health care workers. Also, in addition to that, it would be nice to know if there is some workload analysis, because sometimes while we make reference to policy documents has been done for the sake of primary health care in Nigeria, where it's required a certain number, is also to be realistic from the perspective of health economics to ensure that we are not just hiring people and they'll be redundant. Bearing in mind that some health facilities, especially in the public health setting, they might be located for other reasons, but the need for them. Sometimes people take health facilities as a quote democracy dividend to their people who may not really need an additional health facility, but to be seen that they brought something from political offices. So workload analysis will be important as well to be sure that when you are posting healthcare workers, it's actually being posted based on need. Then Insight Health Consulting also made some brilliant presentations as well as recommendations in this regard, especially stakeholders' engagement, which will be very important, especially at the sub-national levels. They said looking at supporting this National Health Workforce Registry in 25 states and FCT, that's like 26 out of 37, which is very brilliant. One will be wondering what will happen to the other 11 states. This also provides opportunity for participants in this assembly in our various organizations to see if there are organizations that may be interested in supporting that. And if data could be shared to know which states that Insight Health Consulting is going to be doing this and the states that are remaining, that may also be helpful. For instance, I'm the Secretary of National Advocacy for Health, so we are looking at engaging some of the political actors in the incoming dispensation to taking certain actions on health. So if you know those 11 states, that might also be helpful to target them to, even the states themselves can as well support this without necessarily having to be waiting for a private sector partner to getting this done. Then Dr. Nkechi Asogwa, very good presentation as well. And also the last presenter, soon to become doctor. It's very good to know that the organizers brought everyone on the table, from the public, from the private, looking at use of technology in making healthcare available. And this is actually what great value that the Nigerian Economic Summit Group and the Health Policy Commission is providing. One of the last commissions to be set up, but we're already seeing huge or tremendous results in terms of bringing key players in the system and providing realistic solutions for our healthcare needs. I look forward to, some other organizations and also looking at conversation. One of the things in the health space, because I've worked in the infectious disease part, the non-communicable disease part, the policy part, there are a lot of silos in the healthcare sector. So many things are happening, that people from the other device don't get to know about. And this is an area I think this Health Policy Commission is helping to bridge the gap, because within this space, we're having opportunities to engage those in the private health sector. For instance, the Insight Health Consulting, I'm not sure I've quite heard about them, and they've been there for close to 2 decades. So the same with some other key players who are doing fantastic job, especially in the private sector setting. So these interactions and engagements are quite commendable, and we hope the more we do this, the more we get to know what the key players and stakeholders are doing, and the more we also collaborate, among ourselves and also with the state actors in terms of getting results. One of my expectations is that our commission, which of course I'm also part of, and the top 3 winning policy proposals, will add great value as new players are coming into the governance space. Because no matter what we propose, we still need the political actors to make them come to life. Not just at the federal level, there is actually much more work to do at the subnational level. The Federal Ministry of Health actually is mainly in control of the teaching hospitals, in control of the federal medical centers and the specialist centers at the federal level, but largely responsible for policy. But in terms of implementation, the states at the subnational level actually have more work and more control. All the private hospitals in the country get licensed to establish from the states, except for Federal Capital Territory, Abuja, where you have the FCT administration. So all the primary healthcare are also under the control of the state through the primary healthcare development agencies. And of course, other government-owned health facilities are largely directly or indirectly under the control of the state. So as players in this sector, whether for profit or not for profit, making our healthcare systems work, we actually need to be more searchlight on what is happening at the state level. Begin to do some level of comparisons using key indicators, to provide data that could be used by investors as well as advocates to know where we could plug in some of these various challenges that have been noticed. There was this document that was done, I think 2016 or thereabouts, where we're pushing for primary healthcare under one roof. So we use a scorecard to rank the performance of different states in terms of implementation of the primary healthcare under one roof. It was presented at the National Council on Health meeting that year and shared among the different commissioners for health. So just seeing those calls kind of stimulated actions. It was also presented to the Nigerian Governors Forum. So some governors were calling their commissioners to ask, what is happening? So that year, there were 2 states that had 0 score on that implementation. I think Akwa Ibom and Ebonyi State. And just because of that ranking, it kind of inspired the state. Within a year, they passed legislations, took certain actions that significantly improved their ranking. So these are also things we may also look at. On implementation of basic healthcare provision fund, there's also an attempt last year by One Campaign and the National Advocates for Health and a couple of other groups to do some level of ranking. So these also documents that private sector players may also be looking at to know the state of health system within locations they might be looking at to making investments, and also knowing certain areas of intervention that may be required, especially for those who may want to do that as part of their corporate social responsibility. So once again, I thank the NESG Health Policy Commission for the opportunity to be a part of this, and also all the various presenters and the persons who are able to participate physically and virtually. So I really look forward to the next steps, taking all the recommendations that has been made and also seeing them to becoming reality. Thank you very much.
Thank you. Thank you so much, Dr. Laz, for your remarks. Okay, so we move very quickly over to Dr. Hamza. If you have any quick comments for a minute or two, and then we'll have question, comments, and answers, and then we'll close. Dr. Hamza, any quick comments?
Yeah.
Thank you.
Thank you very much. I think just to congratulate all the presenters. As a general comment, these were excellent presentations. All of the presenters, including, surprisingly, Olu Korede, showed like real grasp of the contextual issues that we are facing. In fact, some of the information they've presented here, I'm not aware of. Like you see in Olu Korede's presentation, she mentioned how the federal government is not living up to its promise of, providing 1% of its consolidated revenue funds. It was a pleasant surprise. So by this, you are on your way, Olu Korede, to becoming a very successful health economist, inshallah. If we look at maybe let's take a few comments per presentation. The presentation by Pathfinder was excellent. They are doing excellent work, providing, a platform for a kind of collaborative decision-making between public and private sector in the state. What I would just say is, now going forward, and I also liked the digitization, of data capture and data reporting that they are doing, but always now, especially as to our partners, always try as much as possible to look at how you can build the system holistically, even when you are implementing vertical programs. And then secondly, it seemed like a report. I was very excited by the outcomes, you know, especially when you mentioned 100% skilled bath and deliveries taken by a skilled bath attendant. I was waiting for you to tell me what to do to scale up on, you know, on your experience. Thank God you are in Kaduna. So we'll meet in Kaduna and you'll give me some of this. But you are a bit silent with the recommendations and actionable steps. Olalekan was excellent for Insights Health Consulting, also very knowledgeable of the context, and then very clear with the issues bedeviling our HRH, from planning all the way to implementation and management, and very clear with the solutions. The only question I may have for Olalekan is, when you say support, I know you mentioned governance and the steering committees and so on, but when you say support, what in particular are you referring to is very key, especially for some of us who, like in Kaduna Primary Healthcare Board, we have over 6,000 staff on our record, but we have many more when you put volunteers and so on into consideration. So would that health registry also help, you know, to capture those ones? Dr. Pelumi's presentation had very clear, indicated very clear understanding of the context also. The recommendations were fantastic from Dr. Pelumi. They are big picture presentations. My advice is break them down, maybe capture one or two, start, you know, from experience, always start small. All of the recommendations you made, I loved them. They were on point, but target a few areas where you can make the biggest impact, where you can help us, I think, a lot more with the limited resources that we all know we have. I loved Dr. Nkechi's model. I am a primary healthcare person, so anything to do with community engagement, to do with improving access, I'm all for it, but also a bit more specific. And then, of course, for Olukorede, good information. Thank you. That your picture, amen to it. I know now it's a hopeful, you know, before and after, but I hope you will work hard, and we will all work hard to ensure that we make it a reality. Your recommendations are sound. You are looking at alternative sources to finance healthcare, which is excellent. Donors are already doing a lot. Maybe we need to redirect the way donor funding is it distributed, let me say, in the country, and to what it should, how it should be targeted. Maybe that's one. Private sector, we need to do much, much, much better with the private sector. We need to encourage people to help a bit more. But all in all, congratulations to all of you. Thank you very much.
Fantastic. Thank you so much, Dr. Hamza, for your remarks. I'm sure they all found it very useful. Okay, so it's time for a very quick Q&A with some comments if you have. So maybe one or two questions or comments. So please do engage, you know, let's enrich the conversation. And then also, it would also benefit the NESG for our own conversations going forward. So if you have any comments, if you have any questions, please do feel free to ask or comment now. We can take a couple of questions or comments. Oh, fantastic. Thank you very much.
Well, thank you so much. I think it's really been very interesting. From what I can see today, from the proposals that have been presented, they're really fantastic ideas in the sector, pockets of excellence. But what we are seeing in the field is the inability to not just scale, but to integrate some of these fantastic ideas into the healthcare system. We know that the law has been signed into, the bill has been signed into law, making health insurance mandatory. So what role can NESG play? Because I know that in a sense you support the government in terms of policy and all that, but in terms of enabling environment that would help policy so that private sector can support the government, how can we mentor some of these initiatives into full-blown activities and integrating it into the system? How can we ensure, the implementation of some of the initiatives that the government themselves are holding them accountable? The Basic Healthcare Provision Fund, for one, the statutory budgetary requirements from the state. How do we ensure that it's actually implemented into covering indigents and so on? So there's a lot of activities in the field, but what role can NESG play in terms of making this happen? My name is Njide Ndeli. I'm the country director for Farm Access Foundation.
Thank you very much, Ma. So over to Dr. Morris or Dr. Maria. I don't know if Dr. Maria is. Dr. Maria still online? Can we confirm if Dr. Maria is online? So we'll start with Dr. Morris. Dr. Morris.
Thank you very much, Dr. Njide, and thank you all for staying this long. I'm tired, and I'm sure that some of us are a bit exhausted. But really, I really just feel charged even by your quality of questions and the comments and the presentations that we've heard this morning, is to really assure you, and I think we should invite, Dr. Njide to be a member of the steering committee. I think she just really has good ideas from, taking the conversation beyond words into implementation. And that's what, we spent a lot of time talking about at the last few sessions, is that place of, building capacity in the ways that are not beyond our call as NESG to be able to support really actually integrating some of these solutions into reality within the public sector space. And I think that's where we have to charge, one another further as a Nigerian Economic Summit group. But all in all, do we still have time to take more questions or comments? Oh, we have people here. They've been seated for long. I think we should allow them. Dr. Jacob, please.
Thank you. Thank you, Dr. Morris. So for me, my concern is around the physical challenges from the government's perspective to fund some of these interventions. So the ideas are great, but you see, the ideas without the capacity to fund them, they are meaningless. They are impotent, right? So, and when we talk about percentages and we say, oh, the state government should dedicate XYZ percentage of its budget towards healthcare, it's also meaningless. It's meaningless in the context that if the state government doesn't have sufficient revenues, 20% doesn't mean anything, 30% doesn't mean anything. So it's important that as we progress these ideas, we begin to look at sources or frameworks under which we can fund them. And I heard one of the presenters talk about syntaxes. I can assure you that every sector in Nigeria is targeting those syntaxes. Every sector. So you're not the only one looking at those solutions. As the CEO of the HIV Trust Fund of Nigeria, I've been pounding the streets of Nigeria trying to galvanize the private sector to support Nigeria's HIV response. But what you see is that it's the same usual suspects that support HIV, will support malaria, will support tuberculosis, will support building of primary healthcare centers, will support, and their resources are not finite. Their resources are not infinite. Their resources are finite. So as at NESG and as the health community, and the health community, you also have an echo chamber. We all sit down, we speak throw around all the acronyms, say all these nice things that we say, and come up with all these novel ideas that we don't have the capacity to fund. So one of the things we need to do as a nation at some point is we're going to sit down. We understand government's physical challenges. We understand their shortcomings. We know all the people who support healthcare. We know all the various funds that we have created. There's a litany of them all over the place. We need to aggregate all of them under one fund and determine and prioritize what we should allocate resources to from the private sector, just as the same way government is allocating from the public sector. So it's important that when we do all these things, we will then sit down and say, okay, where can we find this money from? What should we do first? What will catalyze the next step, etc., etc.? That is the fundamental work that we need to do. If we don't do that, then we are like the 6 blind men of Hindustan who went to see an elephant. So each person will say, oh, my own is more important, tuberculosis is more important, HIV is more important, malaria is more important, and we don't get anything done. Thank you.
Thank you so much, Dr. Jeko. Thank you always. Please pass it to...
Yeah, thank you very much. My name is Dr. Noimot Balogun. I would like to take my points from the presentations on the upscaling primary healthcare, and I think the one of logistics. So basically, if we're going to be talking about primary healthcare and all of that, then it means that the local government reforms becomes very critical. Now, the question is, a lot of times people talk about this reform at different fora, but then as the National Economic Summit Group, we now have relatively a new government coming into place. How are we going to be ensuring that this becomes a part of the discussion? If you're going to be talking about local vaccine production and all of that, the local government is important in the logistics channel. So if the central is strengthened and the base isn't strengthened, at the end of the day, we are still going to be having vaccines that will get to the different primary centers, and before they get there, they're already spoiled. So how do we ensure that the local government reforms become a policy discussion that we take down to the very end of it? Thank you.
Thank you so much, Dr. Balogun. We hear you loud and clear. Very true, very critical. It doesn't seem to be happening at the pace that is required for the peculiarity of the situation of this country. Local government needs to be in the conversation, if not prioritized. Because yes, we see all the big grammar at federal level, at state level, and nothing is happening. So I do agree with you. I'm sure the NESG team is hearing, and I've taken down those notes. The last question or comment, please.
Good afternoon, everyone. Thank you very much. My name is Dr. Osa Osweta, MD for AMHS, Alpha Mid Healthcare Management Services. Like everyone has said, everyone is quite focused on what the government can do. I'm from the private sector, and I want to, move us a bit into the private sector. Private sector is money-driven. We all know that. However, if there are policies that can support the private sector in partnership, which is something that is really lacking when it comes to healthcare, partnerships. Private sector understands that they cannot do it alone. Private sector, in all sincerity, don't understand healthcare. When it comes to healthcare, break it down from central, from tertiary to secondary to primary healthcare. The private sector, I'm a medical doctor in the private sector, so I understand healthcare. If the private sector banks, private sector, let's take for example, oil and gas, they don't understand healthcare. But however, if they can partner with they have the policies that can help them partner with the right players, it will change the dynamics. I strongly believe so. So if I'm in private sector and I partner with the primary healthcare board and another partner, the OEMs, the vendors that sell the equipment, all three of us come, sit down, and we create a partnership that will work. And the private sector drives it. We know that government has put down the policies that will make it work, but the private sector will drive it to make it successful. Right. That is also critical.
Absolutely. Thank you very much. Please, a round of applause for everyone that made comments and asked questions. Please be guaranteed that those questions have been taken, your comments have been will be put into consideration, will be implemented as we go on in this discussion. And just to address between the second to the last speaker and the last speaker, there is a transition plan. So we started a 3-day retreat at the beginning of the year just to welcome the incoming government. There is a transition plan, even still modified. So the idea is to get inputs from this General Assembly as well to kind of complement that transition plan. Is going into the incoming. In fact, we're practically waiting for them so that all of these ideas, all of these thought leadership that's has gone on air can fit into that government from the private sector. Now, I want to react lastly to two things. First and foremost is to the presentation and then to the last speaker. To the presentation, there is a component of aggregating and creating a database of health workers. I can't remember who presented it, but please, I want to call you to also consider, once that database exists, there will be a problem of security for health workers. In advanced environments, databases exist for health workers. You know who the nurses, once you put in their name, wherever they are located in the world, it exists. But there is also a lot of security and safety on their lives. You can imagine, because it's a very peculiar sector. Everybody blames the doctor under whose knife somebody died. So once we start getting more advanced, so I expect your presentation to also cover that, is what I'm saying. And lastly, to the last speaker, really thank you for your comments, is to say that at the NESG, this is practically what we're about. It's culminating private sector and public sector conversations. This is the place where it happens. I am not a medical doctor, and I'm the facilitator for the Health Policy Commission of the Nigerian Economic Summit Group. I'm from a multi-sector. I am CEO of an organization that galvanizes private multi-sector to transform health and healthcare at a continental level. I mean, this is the height of collaboration. I'm a living example. And I want to call all of us to that charge, that we're as collaborative as possible as we make ourselves available and as we participate in these conversations going forward. On that note, I'm going to give my closing remarks. I hope I'm allowed to do that. No, so apologetically, Dr. Brown developed a health situation early in the day, so she's not able to join us, but she was listening in.
I joined.
Oh,
yeah,
she did.
I'm here.
Yeah, I did say you were listening in. Thank you, Dr. Ola Brown. It is with great delight that I give this closing remarks of the Health Policy Commission's first General Assembly of the year 2023. And I must commend all of us who waited this long. I mean, it was quite a stretch, especially from the nursing community. I really do appreciate you, madams. Thank you for being here with us. You will agree with me that it has been a very rewarding session over the past 2 hours or more, right, Dr. Shea? 3 hours. Together as a community of health experts, as multi-sector, public sector, there's much work to be done. I mean, you can hear the passion in some of the voices of those who reacted. We've been talking a lot. We need to act and act fast. People are dying in this country, for reasons that are unbelievable. And I'm sure one or two of us have had experiences on health issues that we wish we never had. But we're living, we're the ones alive, so we can speak. There are some that don't have the opportunities to be here. So it's a call to action. It's a call for everyone to be responsible for one another beyond the health workers themselves. I'm a strong advocate for multi-participation and stakeholder engagement on health. It's Africa and Nigeria cannot afford to just assume that the health community can handle it on their own. We're in a peculiar situation, and we must address the situation without peculiarity. As we're all aware, this year is a transition year, and the NESG Health Policy Commission has begun the process of developing transition packs, as I mentioned earlier, to onboard the new government. The General Assembly we just finished today is one of its kind, and we're going to have another one before the year rounds up. I'm sure Sheyi will tell us more about that. On behalf of the members of the Health Policy Commission, Dr. Maria, Dr. Ola Brown, Dr. Sheyi, please give a round of applause for them. They've been incredible. Deborah, they are the brain behind all of this, things that we do and we churn out. Please, we thank you. On behalf of the Commission and as the facilitator of the Health Policy Commission, I want to invite you to the NESG Health Policy Commission to participate more and to engage with us as we continue our mandate to reform the Nigerian health sector. We desire engagement. We want you to participate in your own various capacities that will go beyond this General Assembly. And together we can jointly onboard the incoming government on relevant health sector reforms needed. To join the Health Policy Commission, if you're not a member yet, please feel free to check the NESG website on please, if you care to, can you help me show the link? www.nesg.org. Once again, I thank you all for making out time in your very busy schedules to attend this first General Assembly of the Health Policy Commission of the Nigerian Economic Summit Group. I wish you safe journeys back to your various destinations. God bless you.
Thank you everyone again. So we have some refreshments outside. Please do feel free to help yourselves, and we'll also be taking some pictures in the lobby outside. Thank you so much for your time today.